Vasopressors. So we'll discuss about various aspects of vasopressors used in management of the critically ill patient. What are vasopressors, when they are used, why they are used, and what precautions are needed. Vasopressors increases the blood pressure by stimulating the constriction of blood vessels and increases the vascular tone. Inotropes alter the force or energy of muscular contraction and they increase the myocardial contractility. Shock is a state of inadequate tissue perfusion or oxygen delivery to meet the tissue oxygen requirement. Can be caused by hypovolemia, cardiac function impairment, and inappropriate distribution of the cardiac output secondary to abnormal vasodilatation. Cardiac output depends on heart rate, preload, and contractility. So heart rate is dependent on sympathetic and parasympathetic tone, circulating catecholamines. Preload dependent on the venous return and plasma volume. Contractility depends on sympathetic tone, circulating catecholamines. Septic shock. In septic shock, there is hypotension despite adequate fluid resuscitation, presence of hypoperfusion or organ dysfunction, acidosis, alteration in mental status, sepsis, temperature more than 38 degrees or less than 36 degrees centigrade, heart rate more than 90, respiratory rate 20 beats per minute, need for mechanical ventilation WBC is 12,000 or more. Hemorrhagic shock, there is rapid reduction in blood volume, heart rate, blood pressure response can be variable. Vasopressors may be harmful if the patient is hypovolemic. Despite improvement in the blood pressure, renal blood flow decreases in renal vascular resistance rises. Cardiogenic shock, there could be pump failure, results when more than 40% of myocardium is damaged, similar circulatory and metabolic changes to hemorrhagic shock. Treatment is fluid procedures, drugs like vasopressors and inotropes. Fluid requirement, there is no evidence-based support for one fluid type or other surviving sepsis. Early fluid administration more important than the fluid type. HES, albumin, gelatin, LRN can be used. So adrenergic system depends on alpha adrenergic and beta adrenergic receptors. Alpha adrenergic increases the vascular tone, may decrease the cardiac output, may decrease regional blood flow, and beta adrenergic receptors maintain the blood flow, may increase the cellular metabolism, and may decrease immune system. Dopaminergic system increases the splanchnic and renal perfusion, facilitates resolution of lung edema, and associates with harmful immunologic effect and may decrease prolactin, human growth hormone. Vasopressors, norepinephrine, dopamine, epinephrine, vasopressin, epinephrine. Norepinephrine historically considered as poor choice in shock due to excessive vasoconstriction and end organ hypoperfusion. This opinion began to change recently. Benefit raise arterial blood pressure and systemic vascular resistance, maintain the cardiac function, improve the renal function. Dopamine more potential for the arrhythmias, increase the heart rate, may increase both blood pressures and flow, may be best used in patients with low heart rate and inadequate fluid resuscitation. Epinephrine often used as the third line after norepinephrine and dopamine are failed. Epinephrine always first line for anaphylactic shock. Vasopressors works by V1, V2, and V3 receptors, increases BP, may improve mortality, may decrease norepinephrine requirement, may improve renal function, avoid in MI in cardiac ischemia may decrease the contractility, lower cardiac output, increase mortality. At doses of more than 0.04 units per hour may decrease the GI blood flow. Vasopressin versus norepinephrine, the study is called VASST. There is no significant difference in mortality at 28 days, decreased mortality in patients with less severe septic shock, lowest quartile of arterial lactate. Vaso plus corticosteroid decreases the mortality versus norepinephrine plus corticosteroid. Conclusion may be effective in patients with less severe septic shock already receiving norepinephrine. Martin is a study for norepinephrine septic shock. 97 patients in the septic shock. Dopamine started at 5 micrograms per kg per minute, titrated to 15 micrograms per kg per minute. If hypotension persisted, dopamine increased to 25 microgram or norepinephrine added to 0.5 microgram per kg per minute. Martin et al., the patient receiving norepinephrine had the best survival rates on all day of hospital stay. Mortality is strongly associated with high lactate and low urine output. Norepinephrine was associated with significant decrease in hospital mortality. Data contradict the notion that the norepinephrine potentiates the end organ hypoperfusion through excessive vasoconstriction. DeBacker, norepinephrine versus dopamine in shock, multicenter study, 1679 patients, dopamine with 52.5% mortality, norepinephrine 48.5% mortality, more arrhythmic agents, DA. DeBacker et al. Included the septic, cardiogenic, and hypovolemic shock. More patients in DA group required second pressor. Subgroup DA in cardiogenic shock increased mortality significantly. Conclusion: this study raises the serious concern about the safety of dopamine. So the practical considerations include the vascular access to drugs, compatibilities, titration, and adverse effect. Central versus peripheral line. Central always preferred. Peripheral line must be flushed well, as big as possible. Preferred infusion rate, forearm, basalic, cephalic, and median antebrachial. Caution with dorsum of hand, wrist, and feet. Decision, life versus limb. MD must be aware, and guardrails, alert pressors must go through the central line. Override and MD approval documented, and the slower titration with obese patient. Jim Damon et al. For central line catheters and intravenous access ICU patient. Patient randomized peripheral or central access include epinephrine, norepinephrine doses. Less major complication with central rather than peripheral access. Subcutaneous diffusions, also known as extravasation, more with peripheral rather than central access. All the patient managed with observation and conservative management. Extravasation, dobutamine causes irritant reports of vesicle effect, mechanism of tissue injury, cytotoxic, acidic pH, and dopamine, epinephrine, phenylephrine, norepinephrine, and vasopressin. They have vesicant effect and cause vasoconstriction. Phentolamine is a short-term adrenergic blocking activity. Administration causes vasodilatation of the vascular smooth muscles. Administer ASAP and infiltrate the area of extravasation with phentolamine 5 mg diluted with 9 mL of normal saline. Should see near immediate effect, otherwise consider additional dose. The sequence of event: hypertensive patient, recognize the pressor need, physician order recognize, and pharmacy technician and pharmacist help, and drip is started by the nursing staff. Dopamine and dobutamine, they are premixed. Epinephrine, phenylephrine, norepinephrine, vasopressin, mixed by the nursing staff. Persistent hypertension, ask the doctor if the drip should be sent to the bedside, and call pharmacy and get the drip ready. Compatibilities, we need to check with pharmacy, maybe phenylephrine, and generally not tested in norepinephrine. Titration, starting the drip, doctor must order, and generally best to start low and increase the rate. Adverse effect frequently dose related. Check the patient weight and dosing units. If the same, transition to UW pump and drug indifferent, check with pharmacist. These are the adverse effects of various medication. So norepinephrine can cause tachycardia and arrhythmia, and dobutamine can cause ventricular rhythm. Thank you.